Good evening. My name is Mandar Muzumdar, and I'm a medical oncologist and scientific director for the Center for Gastrointestinal Cancers at Smilow Cancer Hospital and the Yale Cancer Center. I'm delighted to welcome you to our Smilow Shares event tonight, centered on new treatment advances and innovations in pancreatic cancer. We're honored to bring this program to you today to commemorate World Pancreatic Cancer Day, joining a coalition of nearly 100 patient advocacy organizations originating in more than 40 countries across 6 continents to raise awareness of this disease. There's no question that pancreatic cancer is a great challenge, though fortunately it remains a relatively uncommon cancer. It is anticipated that 1 in 64 people will be diagnosed with pancreatic cancer in their lifetime. The disease currently stands as the 10th most common cause of cancer in men and the 8th most common in women in the United States. In contrast, pancreatic cancer is the 4th most common cause of cancer-related death in both men and women, and is expected to rise to the 2nd overall within the next decade. Despite these statistics, there are a number of reasons for optimism. First, the last decade has brought multiple innovations in medical and surgical treatment that has significantly moved the needle on overall outcomes. Second, research, including from labs here at Yale, has provided greater knowledge of the basic biology of pancreatic cancer, which is informing new treatment strategies. Third, the discovery of both genetic and non-genetic risk factors has helped us better identify those at highest risk of developing pancreatic cancer and to formulate new approaches for screening and early detection. And finally, changes in care delivery models towards team-based, multidisciplinary, personalized and holistic care is leading to improved outcomes and quality of life for patients. Tonight, you will hear about these medical and surgical advances, risk factors and screening methods, and team-based holistic care from key experts in our Center for Gastrointestinal Cancers. Our interdisciplinary approach to research, education, and clinical care in pancreatic cancer was recently featured in Breakthroughs, the annual report of the Yale Cancer Center and Smilow Cancer Hospital. I encourage you to read more about our efforts there or ask about them in the question and answer session. Without further ado, I'm pleased to introduce our speakers for tonight. First up will be Dr. Jill Lacy, Professor of Medicine in the section of Medical Oncology, who will be talking about advances in medical treatment of pancreatic cancers. She will be followed by Dr. Ron Salem, Lampman Professor of Surgery and Chief of Surgical Oncology, who will discuss surgical management of pancreatic cancer. Next, Dr. James Farrell, Professor of Medicine in the section of Digestive Diseases, will review risk factors and screening for pancreatic cancer. And finally, Dr. Laura Baum, one of our newest faculty and Assistant Professor of Medicine in the section of Medical Oncology, will talk about palliative care in pancreatic cancer. At the conclusion of the talks, we will answer the questions that you post in the Q&A box, and I will moderate that session. And with that, I'll pass the baton to Dr. Lacy to get started with the talks.
Okay, thank you, Mandar. Well, it's certainly a pleasure to be here this evening. I'd like to welcome all of you and thank you very much for taking some time out of your evening to join us. So I'm going to provide kind of a bird's eye overview of pancreatic cancer and then focus in on our treatment algorithms and in particular the systemic therapies that we utilize to treat this disease. And then I'll conclude with some of the challenges that we face, which Mandar has alluded to, and how we are attacking those challenges moving forward. So I'm going to start with some basics. First of all, terminology. What is pancreatic cancer? When you hear that someone has pancreatic cancer, that usually refers to the most common type of tumors that arises in the pancreas. And the more precise term for pancreatic cancer in that context is pancreatic ductal adenocarcinoma, commonly abbreviated PDAC. And PDAC does in fact represent more than 90% of all cancers that start in the pancreas. And we now know that these tumors arise from the cells that line the ducts of the pancreas. And so to orient you, I have a cartoon here of the pancreas. So it's large organ centered in the mid-abdomen. And one of the main functions of the pancreas is to produce digestive enzymes that are carried through this network of ducts into the first part of the small intestine or the duodenum. And pancreatic ductal adenocarcinomas arise in the cells that line these ducts. And we now know that there are changes in these cells, precancerous, pre-neoplastic changes that can be identified under the microscope, along with a sequence of genetic changes that occur before we have an overt cancer or carcinoma. That process takes place probably over about a decade, but we don't have any mechanism to either prevent that process or really treat it. Now, there are other tumors that arise in the pancreas, and the most common of those are tumors that arise in these little islands or islets of the pancreas. These are cells that produce hormones that are involved in metabolism, most notably insulin, but also others, glucagon. And neuroendocrine tumors, as these are referred to, are the second most common tumors that arise in the pancreas, about 5%. Now, PDACs and neuroendocrine tumors are really completely different diseases in terms of their biology, treatment, natural history. They share in common origin in the pancreas, but really very little else. Tonight, we're going to be focusing in on PDACs, pancreatic ductal adenocarcinomas. Mandar alluded to in his introduction the challenges that surround pancreatic cancer, and those certainly are highlighted by the vital statistics. So as Mandar mentioned, this is not a common cancer, only about 60,000 cases, and this compares to lung cancer, prostate cancer, breast cancer, all over 200,000 cases a year. And although it's about the 10th most common cause of cancer in the United States, I believe it is now inched into third place in terms of leading cause of cancer-related deaths, and moving up, and is projected to be in second place next year. And also in comparison to the common cancers, lung, breast, prostate, colorectal, it does have the most discouraging 5-year survival at just under 11%. And for those patients that have metastatic or stage 4 disease, the 5-year survival is less than 1%. In addition, the majority of patients, 80%, present with advanced disease that cannot be removed surgically. So only 20% of patients have resectable disease at the outset, and thus are potentially curable. However, the news is not all discouraging. There clearly has been incremental progress for our patients with pancreas cancer. Patients are living longer with the disease, and more patients are cured of the disease. Now, this is not due to a giant leap forward, as we've seen in some other cancers like melanoma with immunotherapy, but again, to incremental progress with improvements in surgical techniques and post-op mortality, which we'll hear about, significant advances in supportive care, earlier diagnosis, in part because of the ease of getting imaging, and some improvements in chemotherapy and other systemic therapies. So how do most patients present with pancreatic cancer? Most patients present with vague and non-specific symptoms that can be confused with many other benign conditions. Belly pain, back pain, some weight loss, decrease in appetite, dyspeptic symptoms, nausea, change in their stool habits, just generalized fatigue. About 50% of patients do present with sort of an alarm symptom of yellowing of the skin, eyes, and darkening of the urine, or what we call jaundice. And this is due to tumors located in the head of the pancreas, blocking or obstructing the bile duct, which drains bile from the liver into the duodenum. About 50% of patients, and maybe more, present with either new onset diabetes within the past year, or a worsening of their diabetic control. So there is this very interesting bidirectional relationship between diabetes and pancreas cancer, which we are beginning to understand. Long-standing diabetes does increase modestly, only modestly, the risk of developing pancreatic cancer. And pancreatic cancer itself causes diabetes. And then a smaller percentage of patients will have pancreatitis, inflammation of the pancreas due to blockage of the pancreatic ducts by the tumor. And they may have recurrent bouts of pancreatitis for unexplained reasons. So early detection is a challenge because the symptoms are not alarm symptoms in most patients. They're vague and nonspecific, so there's often a delay. But ultimately, the symptoms will prompt usually imaging, either an ultrasound and then ultimately a CAT scan, which will, in most cases, show a mass in the pancreas, and in most cases will give us great information about the stage or the extent of the disease at diagnosis. But as I had alluded to before, the diagnosis is often made, so to speak, late, with 80% of patients inoperable at diagnosis. So once we are suspicious of the diagnosis of pancreatic cancer, there's a few things that we need to do in the evaluation. First and foremost, we do want to get a biopsy to confirm the diagnosis and be certain of what we are dealing with. And currently, we usually will do that via the endoscope, and this is done by our gastrointestinal, our GI colleagues, and they will obtain a biopsy via ultrasound guided biopsy. Patients who do have jaundice at diagnosis will usually undergo a procedure called an ERCP to have a stent placed to open up the bile duct that will often relieve symptoms quite rapidly and will allow for treatment with chemotherapy. For those patients who on their CT scan had no evidence of spread of disease to other sites in the body, we will always want to get a specialized CAT scan. We call it a CT pancreatic protocol scan. And this will allow us to see the relationship of the tumor to the major blood vessels that course through that area and to see whether there's any involvement, which in some cases may delay or even preclude surgery. And in some cases, we will also get a PET scan that can help with staging. And for all patients now, we are having a discussion about genetic testing. We're going to hear more about risk factors, but about 5 to 8% of patients with pancreatic cancer carry a gene that they inherited from their mother or father that has predisposed them or has caused their pancreatic cancer. Most notably, the BRCA1 and BRCA2 genes that are well associated with breast and ovarian cancer. These two genes are also cancer causing for pancreatic cancer. And since 2018, our professional societies now recommend that all patients with this diagnosis consider undergoing genetic testing to look for a mutation in their germline DNA that is potentially cancer causing. Now, why is this important? Well, certainly it can have real critical implications for the patient and their management. For patients that do carry BRCA, a BRCA mutated tumor, we do have a targeted therapy for these patients. It is a drug called laparib. It has been widely used in BRCA mutated breast and ovarian cancer. And it is a drug that can maintain a remission from chemotherapy and allow patients to be off of chemotherapy and the cycle of endless chemotherapy. And then for those few patients, and this is less than 1%, where we detect a mutation in a family of genes that repair damaged DNA, so-called MMR or mismatch repair genes, these are the few patients that will benefit from immunotherapy. Genetic testing obviously has important implications for family members. They can be tested and potentially go into screening, and we will hear much more about that later this evening. So we've done our workup and we've established this diagnosis. What next? It's critically important that all patients have access to a multidisciplinary review with specialists from all the disciplines involved in caring for this disease. One major goal of this review is to review the CAT scan and to assess resectability. Is the patient a candidate for surgery? What will preclude surgery is distant spread of the disease or extensive vascular involvement. And this review will also define the initial treatment. At Smilow, we have a weekly tumor board multidisciplinary review for our patients. And this is critically important in establishing their care plan and optimizing their care. However, multidisciplinary care does not end with the first tumor board review. Ongoing multidisciplinary management is really critical, again, for optimizing care for our patients. We may engage our radiation oncology colleagues if patients could benefit from radiation. Our gastroenterology colleagues are always involved in the care of our patients, managing duodenal obstruction, biliary obstruction, rebiopsying. And then our palliative care team is really critical in helping manage the tumor-related symptoms. So I'm going to pivot now to a treatment approach to this disease. And as is true in most cancers, that is going to be driven by the extent of disease or the so-called stage. And in pancreas cancer, we really categorize patients into 3 stages: those who have resectable disease, no metastases and no blood vessel involvement; At the other end of the spectrum, those who already have disseminated disease to other sites, metastatic or stage 4 disease, with the liver, belly cavity, lung, and lymph nodes being common sites. And then there's this middle group where there is no evidence of distant spread, but the tumor is growing up to, touching, and growing around blood vessels that are in that area. This group is a continuum from very little blood vessel involvement to quite extensive, and has been broken down into 2 groups. Those where there's very little blood vessel involvement, we define those as borderline resectable, so potentially candidates for surgery, and those who have extensive involvement with tumor growing around major blood vessels, and those are defined as locally advanced unresectable. And then we need to really have a meeting and a discussion with our patients about our goals of our treatment. And those that are resectable or who have borderline resectable disease, those patients clearly are potentially curable, and it's about 30% of our patients. Those that have metastatic disease, treatment is palliative, but in 2021, we still do not have a cure for those patients. And then for this group that have no metastases, but locally advanced unresectable disease, this is a treatable subset. These patients can actually live years in some cases. A few of them will get to surgery if the tumor shrinks off the blood vessels, but there is a low rate of cure for this subset of patients. And then in terms of the treatment algorithm, it's highlighted here. For patients who are resectable, surgery is really the centerpiece, always has been, but surgery alone cures a small percentage of patients. And so using chemotherapy, and in 2021, that is the complicated 3-drug regimen FOLFIRINOX, we have really dramatically increased the cure rate for these patients. So 6 months of chemotherapy is generally the recommended treatment course along with surgery for these patients. For those that do have blood vessel involvement, we really now have moved towards administering chemotherapy initially to virtually all of these patients to reduce their disease burden and hopefully enhance the success rate of surgery. And then after usually 4 to 6 months, they may become surgical candidates. If surgery is not possible, they often will go on to radiation to maintain protracted disease control. And then for our patients with stage 4 metastatic disease, we will be generally treating them with palliative chemotherapy. So I mentioned that the progress in this disease has been incremental, and that's largely true. Although in our patients with resectable disease, I think we can say that we did have a giant leap forward in 2018. So prior to that period of time, about 20% of patients present with resectable disease, and with surgery and the chemotherapies that we were using up to that point, only about 20 to 25% of those patients were cured. In 2018, we learned about the results of a pivotal trial using FOLFIRINOX after surgery for 6 months in these patients who've undergone surgery. And that a treatment doubled the survival, the 5-year survival, from about 25% to nearly 50%. And that was heralded as an immediately practice-changing observation, and really, truly was the biggest advance for pancreatic cancer that we had seen in my career and in the previous 25 years. So just a few comments about the regimens that we use in pancreas cancer. The standard of care FDA-approved list is quite short. I highlighted FOLFIRINOX. This is a regimen that has made a difference, unprecedented benefit in all stages of disease. It is an essential component of curative treatment. But the benefit of FOLFIRINOX is at some expense in terms of quality of life. It can be associated with significant toxicities and side effects. So it can be a tough regimen for some of our patients. A couple of years after we learned about FOLFIRINOX and it was first evaluated in stage 4 disease, then we learned about a 2-drug regimen, which is now widely used in the metastatic setting, gemcitabine and nab-paclitaxel, a simpler regimen than FOLFIRINOX, better tolerated, particularly in our older and frailer patients. And it is a regimen that we can also use in our locally advanced unresectable patients. Irinotecan, an old drug, it's in the FOLFIRINOX regimen, has been reformulated. And this may have some advantages, and this is also used in the metastatic setting. We have at present only 2 targeted drugs that we can use in this disease. I've already mentioned laparib for those patients with a BRCA-mutated pancreas cancer. It improves disease control as a maintenance treatment after induction fulfillingox and does allow patients a break from endless chemotherapy. And then immunotherapy, which has been so critical for increasing the cure rate of other cancers, can be used in that 1% of patients that carry this mismatch repair deficiency in their tumor's DNA. Now, in contrast to resectable disease, we really haven't had a major leap forward in terms of progress in the metastatic setting, although in 2011, fulfillingox did emerge as a major advance with a doubling of the median survival in patients with metastatic disease, and is now widely used along with the other regimens that I mentioned. So there has been an acceleration in the pace of drug discovery and improvements in treatment in the metastatic setting. So this is a busy, complicated slide. I do apologize, but it is the algorithm that we incorporate in treatment decisions for our patients with metastatic disease. Now, the vast majority will be this middle group, but I do want to highlight that when we are dealing with metastatic disease, in addition to the genetic testing for mutations that a patient may have inherited, we also strongly recommend and attempt to do this in every patient, and that is what's referred to as tumor profiling or genetic profiling or molecular profiling. So this is analysis of the DNA of the tumor itself. We will always find mutations, and what we're really looking for are mutations for which we may have a drug that may be active, so actionable or druggable mutations. Again, most patients will fall into this middle group. No BRCA mutation, no deficiency in mismatch repair. They will usually be treated with chemotherapy. For those that are BRCA mutated, chemotherapy, and then maintenance olaparib is an option. And those few patients who have MMR deficiency can go on and receive immunotherapy. I've highlighted at the bottom, enrollment in a clinical trial in this disease is always a consideration at every phase, from beginning to the last line of treatment. So Mandar highlighted at the beginning the challenges of pancreatic cancer, and I'm highlighting the same here. I've already alluded to the fact that most patients present with advanced disease. So the challenge is that we do not have an easy, accurate screen for the general population for early detection of this disease. And then there are really complex biological challenges that have really challenged us in developing new therapeutics. And I've again highlighted just a few of them here. This is a tumor that infiltrates locally around blood vessels, so it makes resection more difficult. It metastasizes early and often before we even see a mass on imaging. This tumor grows in a protective, complex scar-like material or stroma, and that really, we talk about a protective shield that this confers, interferes with immune effector cells and chemotherapy penetrating the tumor, while at the same time giving the tumor a growth advantage. Pancreatic ductal adenocarcinomas are unfortunately invisible to the immune system, in part because of this stroma, and thus they are resistant to the current immunotherapies that have been so impactful in other tumors. And then in pancreatic cancer, we do encounter recurring, very common mutations. Notably, a gene called KRAS is mutated in more than 90% of patients, and P53 right behind. And for all of my career, until literally the last year or so, certainly these have been considered not druggable, but now we have a drug that's FDA approved for a specific KRAS mutation. And there are a whole host of other drugs in the pipeline that will be coming into the clinic in the next year or two that should be targeting some of the mutations in KRAS that we encounter in pancreas cancer. So our understanding of these challenges, as difficult as it is to list them, really is helping us to develop new therapies, really to get at these challenges. So it's not all discouraging. I think really there is much hope in terms of what's on the horizon. So certainly immunotherapy, I think, will become an effective tool for treating this disease. We're not there yet. but there's intensive research looking at new immunotherapy combinations. We have a number of trials at Yale looking at combining new immunotherapeutics with the current generation, along with other strategies, including chemotherapy, and I think we'll get there. There's intense interest in looking at drugs to disrupt that protective and growth promoting stroma or scar-like tissue. This is a new area, but I think this holds great promise, and these drugs will likely be combined with, for example, immunotherapies or chemotherapy to enhance effectiveness. I mentioned inhibitors of KRAS. We know that's coming. I think that's one of the most exciting possibilities in the future for our patients with PDAC. And again, we expect these drugs to be in the clinic in the next few years. Another strategy that's really just getting going is targeting the very altered metabolism and energy utilization of pancreatic cancer. We can utilize that and exploit that to treat this cancer. And then finally, more drugs that we can use to exploit the impaired repair of damaged DNA that occurs not only in the BRCA mutated tumors, but in many other of our pancreatic cancer patients. And we're learning this as we do more genomic analysis on these tumors. I think ultimately we'll be seeing combination strategies. I mentioned targeting the stroma in combination with immunotherapy, also with chemotherapy, and I think that is going to be the key to the future. So I think we're really expecting to see an explosion of new therapies coming online over the next decade. It certainly, I know to this audience, cannot come quickly enough, but I think there certainly is every reason to be hopeful. And thank you.
Thank you, Dr. Lacy. We'll move on to Dr. Salem.
Share my screen. Great, can you see my screen? Well, thank you to Mandar for the introduction, and thank you to everyone for joining us this evening. It's particularly nice to see some of the names of some individuals who I've known for so long, as well as some individuals who I've had the pleasure only of meeting rather recently. So thank you so much for joining. I'd like to present to you some of what we do in the surgery for pancreas cancer and some of the challenges and where I think we have had advances. So this is from the cancer database. And here you can see that in the estimated number of new cases of pancreas cancer in 2021 is about 60,000. And this has actually gone up fairly substantially over the course of time. The estimated death rate is 48,000. As you can see here, which is round about the time that I started doing pancreas surgery at Yale, the death rate and the new cases rate was almost identical. And as you see, as time has gone on, these two lines have parted slightly, but we so do wish that they would actually diverge a little bit more. And as you heard, the relative survival rate is 10.8%, but we do have hope that the survival rate will go up with some of the modalities that Dr. Lacy explained to you and some of the other areas that you will hear about shortly. And as you just heard in the previous presentation, only 20% of patients who are identified initially with pancreas cancer are able to undergo surgery. And in patients who do not undergo surgery, there is no 5-year survival. So the surgical management of pancreas cancer starts with the workup. And I tell patients that there are two things that you have to do first. First of all, you have to ensure that there is no evidence of spread. And secondly, you have to ensure that the tumor is removable. And as you heard, by and large, that revolves around the fact that the tumor does not involve any of the major blood vessels in such a way that they are not reconstructible. And in addition, we have to determine that the patient is sufficiently healthy in order to tolerate the surgery, which on occasion can be very, very extensive. And it's also important for us to stage and classify the disease according to what you heard by Dr. Lacy into resectable, borderline, locally advanced, and metastatic. And the treatment of these is as already discussed by Dr. Lacy. So let me show you the pancreas. The pancreas is that banana in the middle, that sort of brownish area that is surrounded. Here's that brownish area. This is the pancreas. It's surrounded by the beginning of the small intestine or the duodenum. It has the bile duct going through it, right through it. It has the gallbladder close by. It has the artery to the small intestine, which is known as the superior mesenteric artery, and the vein that takes the blood back, which is the superior mesenteric vein, and finally, the portal vein. And as many of you know, the pancreas is divided by two imaginary lines into the head, the body, and the tail. And the surgery or the type of resection that is carried out depends on the location. If the lesion is in the head, we carry out a Whipple procedure that you may have heard of, and sometimes a pylorus preserving Whipple procedure, which we shall explain shortly. If the lesion is in the body or the tail, we do what's called a distal pancreatectomy and splenectomy. And I'll explain the reason for the splenectomy shortly. So as many of you who I have actually seen in the past, and for all of my patients who come to see me, this is the diagram that I will always draw to explain the actual process of resection. So I would like to do that now. So here's the esophagus that takes food all the way down into the stomach, and here's the stomach. This is the beginning of the small intestine or the duodenum, and here's the pancreas and the pancreatic duct that goes right through the pancreas itself. Here's the liver, this is the bile duct, and here's the gallbladder. So that's the anatomy of the area. Now, when we talk about a tumor, a pancreatic adenocarcinoma in the head of the pancreas, this is the type of surgery that's required. This is what needs to be removed. We have to remove the head of the pancreas along this red line here. We have to remove the bottom part of the bile duct along with the gallbladder. We have to remove a portion of the small intestine as shown, and occasionally we'll need to remove some of the stomach as well, depending on how advanced and large the tumor is. This is the pylorus, which separates the stomach from the duodenum. And if we have to take a portion of the stomach, this will be known as a classic Whipple procedure or a pancreatico-duodenectomy. If we are able to save the pylorus, then we will carry out a pylorus-preserving Whipple procedure or a pylorus-preserving pancreatico-duodenectomy. And once that resection is done, the pancreas gets joined or anastomosed to the small intestine like this. The bile duct, now without the gallbladder, gets joined to the small intestine like this. And the beginning of the duodenum or stomach gets joined to the intestine like this. And so that's the reconstruction that we would see post-Whipple procedure. And how do people do after the Whipple procedure? Well, it's approximately a 6-hour operation. It's not common that people would require a blood transfusion about 5 to 10% of the time. And in general, patients will stay one night in the surgical intensive care unit. On postoperative days 1 and 2, we will start fluids by mouth. And on the 3rd and 4th day, patients will start taking solid food. And if there are no complications, the average day of discharge will be approximately on day 5, sometimes as early as day 3, but sometimes you can get complications, which we'll come to. After surgery, patients find that they're only able to eat small meals. And so they'll have to have meals about half the size of normal and have a good sized snack in between meals. And this is something that will need to take place for approximately 6 weeks. But by about 6 to 8 weeks, the vast majority of patients are back to eating normally. Now, the majority of the cells that create insulin are in the body in the tail of the pancreas. So after the Whipple procedure, it's unlikely that patients will require insulin if they were not diabetic prior to surgery. Now, the pancreas, as Dr. Lacy pointed out, also creates enzymes to help us with digestion, particularly fat. And those enzymes are evenly distributed along the pancreas. And often patients with pancreas cancer will already have some degree of enzyme deficiency. And oftentimes patients who have a Whipple procedure for pancreas cancer will require pancreatic enzyme supplementation. And this will take place by taking a pill right at the very beginning of the meal or just at the time of taking a large snack. Now, as I mentioned, there are complications that are associated with an operation of this magnitude. And the complications we see the most would be an anastomotic leak, which means leakage from one of the reconstructions. And that most commonly is a reconstruction of the pancreatic duct. Interestingly, in those patients who receive a Whipple procedure for pancreas cancer, the likelihood of a pancreatic duct leak is much lower than patients who receive a Whipple procedure for other reasons. Patients may find that it just takes time for the stomach to start working again, and we call that delayed gastric emptying. It's a nuisance, but it takes time and eventually it resolves. You can get bleeding, you can get infection, and you can even die from this operation. Now, in the centers around the country that are high referral centers, in other words, places where they do a lot of Whipple procedures, the mortality rate of this operation is about 3%. That means 3 out of every 100 patients will die from the procedure. If you look at places where the volume is much lower, the mortality can be up to 20%, which is really very high. In our institute here at Yale, the mortality rate is 1%. Of course, we can also get the complications you get with any type of surgery. You can get blood clots, you can get pneumonias, you can get other infections such as urine infections, and other infections can take place as well. Now, all of these complications are reduced in high volume centers. And that's really very, very important. And we've identified that fact over the last 10 to 15 years. And increasingly now, patients with pancreas cancer requiring surgery will be referred to high volume centers. Now, Dr. Lacy pointed out that this is a multidisciplinary type of care that's required. But in addition to that, the type of care that's required is the care that you see in high volume centers, nurses who are able to identify problems before they become dangerous, surgical intensive care units that can treat patients with complications, interventional radiology and interventional gastroenterology who can help us with complications and avoid any long-term morbidity and clearly any long-term mortality that might be associated with this procedure. I shall move on now to distal pancreatectomy and splenectomy, which is the procedure that is used for tumors that are located in the pancreatic body and tail. Now, we take out this part of the pancreas because that's where the lesion is located. But many patients ask, well, why do you take out the spleen? And the answer goes like this, that the blood vessels that go to the spleen are very closely approximated to the pancreas. And if one tries to preserve them, one risks leaving some cancer on those blood vessels. And in addition, the lymphatic drainage, the drainage where cancer goes to lymph glands, goes towards the spleen. So many of the times when there is metastatic disease to lymph nodes, those lymph nodes are located around the spleen, and hence the spleen needs to be removed. This procedure is shorter than a Whipple procedure. It's only about 3 hours. No reconstructions are necessary, and no removal of any intestine is required. This operation is often done laparoscopically. The hospital stay is only 3 days on average, and there's no need for intensive care units, and there is a quicker recovery. Now, the function of the pancreas will generally be preserved by what's being left behind in the head and in the neck of the pancreas. But the loss of the spleen, most of the functions of the spleen will be taken over by the liver, all except for one, which is the ability to protect oneself against 3 different infections, 2 pneumonias and a meningitis. And when you take out the spleen, we will give immunizations against those 3 infections, so patients are covered. So as we outlined right at the very beginning, what are the advances? And the advances in the surgical management of pancreas cancer revolve mainly around several issues, several domains. One is the identification of early stage disease, which I think you may hear from Dr. Farrell. Now, we know that there are certain disease processes that predispose one to pancreas cancer, and they are pre-malignant in nature. And we also know that improvements in the survival rate in pancreas cancer are really quite difficult to come by. So if we can identify a patient who has a lesion that is just about to become malignant or has become only just malignant at the earliest stage, we are offering the patient a great advantage by curing them or avoiding a disease that has a very high mortality rate. We certainly know that we are able to make certain unresectable tumors resectable by neoadjuvant therapy. Whether that translates into improved long-term survival is unclear. And the treatment of patients in high volume centers is something that I have alluded to already. But what have we done here? So at Yale, what we've done over the last 15 years is we've done a very thorough analysis of all the modifiable risk factors that exist for complications. We've identified what we can do to reduce the pancreatic fistula rate. We've identified what we can do to reduce delayed gastric emptying and to reduce the length of stay in hospital and facilitate early treatment with chemotherapy. So many of these patients have systemic disease that's occult, that if we can get them onto chemotherapy expeditiously, we're offering them best opportunity of cure. In addition to that, we enroll our patients in international quality outcome databases where we're able to compare our results with others, and we're able to learn how to improve our management by the evaluation of large databases. Laparoscopic and robotic approaches are present, but currently they don't appear to be ready for prime time and have not yet really improved the outcome of these patients. So we enrolled all of our patients into the National Surgical Quality Improvement Project and have found that our fistula rate and our rate of delayed gastric emptying is in the top 10% of the country, and our length of stay is similarly so. So this work has paid off and gives an idea of how this is an area where so many different disciplines come together in order to provide the very best outcome to our patients. And we are extremely grateful to our nursing staff, to our interventional radiologists and gastroenterologists for what they do to help us in the surgical management of this disease process. And one of my patients who had a Whipple procedure many years ago decided to name their pet goat Whipple, and here is a picture of Whipple. So hopefully, if you have any questions, hopefully I've answered some of the questions that you might have, and we look forward to questions at the end of the session. Thank you very much.
Thank you, Dr. Salem. Please enter your questions into the Q&A box at any time, and we'll get to them at the conclusion of the talks.
I'll take it from here. Thanks again, Mandar, and to Smilow for organizing this evening. I know it's late, and I appreciate everybody being here and participating in this symposium. You've heard talk about treatment from both the surgical and medical perspective. My goal in life is to be at the other end in terms of early detection and finding this sooner and understanding how this disease occurs and who's at risk for getting it. So I've been tasked with dealing with and talking about risk factors and screening for pancreatic cancer. There we go. So some of this has been covered already, but I think it's worth making the point that unfortunately with pancreatic cancer specifically, a lot of the symptoms that we deal with are very non-specific. And as you've heard, are often late. And so there's not one symptom that points to saying, oh, this is clearly a problem with the pancreas. A lot of the symptoms that we deal with could be attributed to your stomach or your gallbladder or your colon, for example. And this needs to be kept in mind. And also in terms of perspective for individuals concerned about having this disease and realizing that, you know, it's still an uncommon disease, although certainly rising in incidence. And there are many, many other benign conditions of the GI tract and abdomen that can also present with similar symptoms. This has also been mentioned before in terms of how this disease is changing over time and becoming a more common disease, and with these concerns that by 2030 or so that it will probably account for a large number of cancer-related deaths of all the entire cancer population. And while there have been advances with respect to the treatment, and you've heard about some great advances with respect to medical treatment and surgical treatment of pancreatic cancer, we do believe that there needs to be further advances made with respect to early detection, similar to what you've heard when people talk about colon cancer screening or breast cancer screening. So I'm going to broadly talk about, you know, some ideas relating to this for the general population as well as the high-risk groups. Specifically, when we talk about the general population, the idea will be very similar to having a colonoscopy at the age of 50 or breast cancer screening. That's something we could apply to everybody, not just people at increased risk. And so there is increased interest in this area with respect to blood tests and the possibility of could there be a blood test that everybody could get access to that would pick up pancreatic cancer early. And there's a lot of different tests that you're going to hear more and more about it over the next couple of years. This is one particular type of blood test. It's what's called a multi-cancer blood test. So this is a blood test that's designed to actually identify multiple different types of cancer, not just pancreatic cancer. For this one, this is called CancerSeek, and the study that was designed to analyze it was called the TECH study. And this was designed to identify colon cancer, breast cancer, ovarian cancer, kidney cancer, but also pancreas cancer. This particular study had to study about 10,000 patients. And of those 10,000 patients, only 134 patients had a positive abnormal blood test. And ultimately, only 26 cancers were detected. So this just gives you a broad idea about how challenging this area is, but also how uncommon some of these diseases that we're actually trying to chase are. Over on the right-hand side here, a lot of the cancers that were found turned out to be breast cancer, lung cancer, and interestingly, there were no pancreas cancers identified in this particular study. Again, this is a multi-cancer blood test. It tries to identify a broad sweep of different cancers. So there have been some advances to try and develop cancer blood tests that are more specific for pancreatic disease and pancreatic cancer. This is one particular type called the IMRAE PanCan-D study that uses a variety of blood markers that are kind of pooled together and tested. And when you hear about this test, you hear some very positive things about it in terms of how good it functions. We talk about operating characteristics. But the reality is that when this blood test is then applied to a general population, it results in what we call a lot of false positive tests, meaning people are told that they have a positive blood test. But after we complete the workup, which could include CAT scans and MRI scans and endoscopies, the vast majority of patients will not end up having cancer. For sure, we will find some, but it causes, you can imagine, a lot of unnecessary worry. So this is one of the major problems and challenges we have when we try to develop tests for the general population. And that's why we then start to focus more on what we call high-risk groups. So people who are at an increased risk of developing pancreatic cancer. One of these groups are individuals who have pancreatic cysts. This was alluded to by Dr. Salem earlier on. Pancreatic cysts, these are little fluid collections in the pancreas are incredibly common in the population. Maybe about 6 million people in the United States alone probably have some form of a pancreatic cyst. They're picked up incidentally by CAT scans or MRI scans are done. Here's a small little cyst sitting in the pancreas, or here's an MRI scan showing multiple cysts. And we know for a fact that some of these cysts, again, not all of these cysts, but some of these cysts can go on and develop a cancer in the cyst. And this is something that we're concerned about and we follow, and we do a lot of investigations to figure out. Interestingly, we also know that in patients that have these cysts, they may also develop a pancreatic cancer somewhere else in the gland, albeit at a very small rate. But it's important to make the point that the vast majority of people who have pancreatic cysts, despite everything that I've said, nothing happens. Their cyst doesn't change. They certainly don't undergo pancreatic surgery. And the vast majority of them do not develop cancer. So a lot of work and emphasis is in this area trying to figure out which patients are truly at risk and which patients are not. Another high-risk group are those individuals that have either a familial or a genetic risk of pancreatic cancer. I won't challenge people to tell me who these people in the picture are, but it's important to understand that if you have increasing numbers of first-degree relatives in your family with pancreatic cancer, your risk of developing pancreatic cancer actually increases. So as you go from having 1 first-degree relative to 2 first-degree relatives, all the way up to 3 first-degree relatives, your relative risk, your rate of developing or your risk of developing pancreatic cancer increases significantly. When we look at this and try to understand what's being inherited here, what are the genes, the most common gene found in this scenario is the BRCA2 gene, but it still doesn't account for the vast majority of patients who have this familial risk. And so we don't understand everything about familial pancreatic cancer. Maybe it's a shared environmental issue. Maybe it's the microbiome. Maybe it's the bugs in your gut that are contributing to this. I will apologize for this slide, but I've tried to make it as more readable as possible, but it's an important slide. Here is a list of the currently accepted pancreas cancer susceptibility genes that are in all our DNA that we carry around in what we call our germline, as opposed to being in the tumor. They're listed here on the left-hand side. You've heard about some of them before. There's BRCA2, ATM. There's some particularly high-risk ones called like CDKN2A or P16. There's a Peutz-Jeghers gene down here, STK11. There's also an intermediate risk group, including BRCA2, ATM, and PALB2, and then some lower risk genes, such as those seen in Lynch syndrome. And these all have a varying rate of risk or relative risk of developing pancreatic cancer. But on the flip side, they're also found in individuals who present with sporadic pancreatic cancer. They're also associated, as you can understand, like with BRCA2 and BRCA1, with the risk of developing other cancers, such as breast cancer and ovarian cancer. So what do we do with this type of information, this information that we have available to us? One thing is we're able to risk or give advice to people about lifestyle modification. So for example, hereditary pancreatitis is a well-characterized gene that's inherited, where patients present with recurrent attacks of pancreatitis at a relatively early age. By the time that their pancreas is diseased and is resulting in problems with absorption and diabetes, they're well into their 20s and 30s. And then the risk of pancreatic cancer takes off at a much earlier age than the general population in these patients' age of 40s and 50s. What we know is that if these patients smoke, and if we ask these patients to stop smoking, because smoking is a significant risk factor for pancreatic cancer, they can reduce their risk of developing pancreatic cancer. We assume, but we actually don't have a lot of data that this applies to other genetic risk factor individuals, such as the BRCA2 population, but we certainly assume that's likely true. The second thing that we do with this sort of information about knowledge of genes that we carry that increase people's susceptibility to developing pancreatic cancer is develop some form of surveillance program to try and see if we can find either the cancers early or even the precancers early. This, as Dr. Lacy and Dr. Salem alluded to, really takes a multidisciplinary approach where a combination of imaging with radiology, such as an MRI or CT scan, in combination then with an endoscopic ultrasound to take a very close look at the pancreas to see if we can identify, again, early masses or cysts that are concerning the pancreas that we would recommend patients undergo surgical resection for to either manage an early cancer or to manage a patient who has a pre-invasive lesion. For this, we have a pancreatic cancer early detection clinic established through the Smilow Cancer Genetics Group. And through this group, we look and we follow a large group of patients in our pancreas cancer surveillance program. These groups I've kind of alluded to before, but I'll just go over them one more time. There's a high-risk group, such as those individuals with Peutz-Jeghers syndrome. There's this very large cohort of individuals who have just a family history, be it 2 or more first or second degree relatives with pancreatic cancer, but no obvious germline gene abnormality that we can find on a blood test. Then there are those variety of individuals who carry germline mutations in their blood. And for most of these individuals, I think it's important to state, they need to have at least one family member with pancreatic cancer before their risk becomes significant. The exceptions are P16 for this particular group. And then finally, the group of hereditary pancreatitis that I alluded to before. So far, we're following about 205 patients, again, with a broad inclusion of indications, including predominantly family history alone, as well as a large cohort of individuals with BRCA2 gene mutations. The third thing that we do with this piece of information about gene susceptibility for pancreatic cancer is kind of flip it upside down. And what's been noticed is that if you take all individuals presenting with pancreatic cancer, about 10% of them, if you check their blood, will carry one of these genes or carry some gene that is related to pancreatic cancer development or cancer development in general. So it'll include, again, BRCA2, ATM, P53, the APC gene, and the Lynch genes. So across the board, a large percentage or a sizable percentage of individuals who present with pancreatic cancer, and we're not talking about looking at the tumor itself, but looking in their blood, will have an abnormality. And what that has led to is our national guidelines changing in 2019 to state that all newly diagnosed pancreatic ductal adenocarcinoma patients undergo what's called germline testing. So Dr. Lacy alluded to this earlier on. This is in addition to tumor testing for patients who have both local disease as well as metastatic disease. And so, as I say, all patients now with the diagnosis of pancreatic cancer should be offered genetic testing regardless of their age. If a patient declines testing or unfortunately dies prior to having testing, it is recommended that a first-degree relative of that patient is offered testing. There are multiple platforms which provide adequate testing. They're not just limited to the BRCA variants. As I say, they typically encompass a long list that I've shown you. And if patients have had previous testing just for BRCA, it's recommended that that be updated. And as again, Dr. Lacy alluded to, positive tests also have implications for treatment. But in the early detection sphere, the concept of cascade testing is now front and center. And the idea is that a patient who is presented with pancreatic cancer and who undergoes germline testing and is found to have a positive or worrisome germline mutation, that patient's family or first degree relatives at least are then educated and are made to understand the significance that not only is there a pancreatic cancer in the family, but that there is likely a germline mutation, and that has implications for first degree relatives. So siblings, children, parents. This is just an example of an individual with pancreatic cancer here who had a PALB2 mutation. At least 4 individuals were tested, 1, 2, 3, and 4 up here within the family. 2 of them were found to be carriers of the PALB2 mutation and are undergoing pancreatic cancer surveillance. So this is the world of cascade testing, which you're going to hear more and more of. I'd like to finish up on the final high-risk category that we are concerned about, and this is diabetes. There is a link between diabetes and pancreatic cancer. For sure, individuals with long-standing diabetes has been appreciated are at risk for developing pancreatic cancer. But there's probably a more important and significant relationship going on whereby pancreatic cancer actually results and develops sugar abnormalities, ultimately resulting in diabetes. There are a large number of patients with the diagnosis of type 2 diabetes. This is a late onset diabetes presenting in the United States. In fact, when you look at all patients presenting with pancreatic ductal adenocarcinoma, a blood sugar abnormality can be found in up to 85% of this group. Now, they're not all diabetic, and it's probably the classic new onset diabetic population within newly diagnosed pancreatic ductal adenocarcinoma is probably of the order of 20%. But when you look at other ways of looking at blood glucose abnormalities, be it advanced pre-diabetic stages or impaired fasting glucose, the total number is actually quite a significant number. And some of you are probably familiar with this, presentations of diabetes a year or two before a diagnosis of pancreatic cancer, or more difficult to control diabetes leading up to before a diagnosis of pancreatic cancer was made. When this has been studied and individuals have looked at patients presenting with pancreatic cancer and diabetes, we've been able to follow these patients back to about 3 years before their diagnosis of pancreatic cancer and being able to find some blood sugar abnormality. Now, it's a very subtle abnormality that's there, and these patients didn't present with frank diabetes until about 6 to 12 months before their presentation of pancreatic cancer. But there's clearly something going on here that is interesting on a certain kind of clinical level, but also provides us a very unique way of now trying to identify yet another high-risk group of patients that we can target for surveillance for pancreatic cancer. And there's a variety of studies underway nationally, but also here in Connecticut, that look at new onset hyperglycemia and diabetes as a way of identifying patients with newly diagnosed pancreatic cancer. So in summary, we're not ready for general population screening just yet, but there is a lot of work going on with respect to trying to develop blood tests that would be highly accurate. But for now, we're focusing on high-risk groups, pancreatic cysts, which we've mentioned, individuals with a family history and who are inheriting genes that are increasing risk of developing pancreatic cancer, and this new area of germline testing for affected asymptomatic family members. But also keep your eye on the area of new onset diabetes, because it's clearly associated with an increased risk of pancreatic cancer. And we hope to be able to harness this to identify more patients at an earlier stage. I will thank you for your attention and just leave you here with a list of the ongoing pancreatic cancer surveillance clinical studies that are open at Yale in the realm of pancreatic cysts, familial pancreatic cancer, and now more recently, diabetes. Thank you.
Thanks, Dr. Farrell. We will close with Dr. Baum.
Hi, let me see if I can share my screen. Can you guys see and hear me okay?
We can hear you, but no screen yet.
No screen yet.
Oh, it didn't work. Okay. Let me try again. How about now?
You're good.
Okay, great. So thank you so much for including me tonight in this talk. I'm honored to be here to discuss the role of palliative care in pancreas cancer. So in the next 10 to 15 minutes, we'll discuss the basics of what is palliative care conceptually and theoretically, and what it is here at Smilow. And we'll talk about when is the right time during pancreas cancer treatment to get involved with the palliative care team. We will also discuss the common question of what is the difference between palliative care and hospice. Does anyone recognize the graphic? I don't have audience participation because I can't see all of you, but that is the 7th floor healing garden by the Hematology Infusion Suite. So palliative care is a specialized type of medical care, which is sometimes called supportive oncology in the context of cancer care, and I think helps conceptualize it for patients. Palliative care doctors complete an advanced specialized fellowship in palliative medicine, including how to address pain and symptoms and assist with complex medical decision-making, prognosis, and communication. But palliative care is usually provided by a whole team of providers, including doctors, nurses, psychologists, pharmacists, and other clinicians who can provide an added layer of support for patients and families facing life-threatening illnesses. Palliative care is focused on the patient and their family in order to help provide the care that is best for that particular patient. Like I mentioned, palliative care is for patients and families with a life-threatening or life-limiting illness to support them through their disease course, including symptom management, understanding prognosis, and when appropriate, assisting with end-of-life care, legacy building, and decision-making. This graphic shows a view of health as the intersection of physical, mental, social, and spiritual well-being, which are all part of a holistic view of our well-being and good health as humans. Cancer is obviously a disease of the physical body, but pancreas cancer impacts all areas of our health. The approach of palliative care is to treat the person holistically, considering the aspects of their treatment and well-being other than fighting the cancer itself that can be addressed to improve their care. This includes physical, mental, social, and spiritual health, and it means understanding how the illness is impacting the patient as a person. In this graphic, you see the palliative care treatment team. In the center is the patient and family. Surrounding the patient and family and also working together are different members of the palliative care team. The graphic includes doctors, nurse practitioners, spiritual care providers such as chaplains and social workers, but there are others not represented in this pictorial. Given the big picture holistic view of patient care and the fact that each person has different needs, whether spiritual, physical, emotional, etc., the palliative care team is multidisciplinary. Multidisciplinary means that it's many different types of providers. And here at Smilow, like I mentioned, we don't just have physicians, nurse practitioners, chaplains, and social workers. We also have bereavement counselors, nurse coordinators, nurses, art therapists, pharmacists, and a collaboration with the Yale Law School for issues related to custody or legacy or other legal issues that arise when facing a life-limiting or life-threatening illness. We have inpatient and outpatient palliative care available. And the outpatient is for oncology patients only, for cancer patients only, but that includes longitudinal follow-up with the palliative care interdisciplinary team. So the Yale palliative care services, just to detail that a little more specifically, includes an inpatient consult service for both adults and children, pediatric patients, for cancer and non-cancer teams. And then in the outpatient, it includes a cancer-only outpatient consult service, which has scheduled clinics Mondays through Fridays and is available at both New Haven and North Haven. So thus palliative care can be provided in the hospital as a consult service or in the outpatient setting as a consult service at the same site as your visit with your oncology team. In the future, home-based palliative care may also be an option depending on insurance, but is not yet available as a standard treatment at Smilow. Oh, sorry. There we go. So the question we now turn to is, when is it appropriate to involve palliative care in pancreas cancer treatment? Here you see two graphics on the cancer care continuum. That means the way that cancer is treated over time. The first shows an old-fashioned model of palliative care, where palliative care is simply used as a transition to end-of-life care or hospice care in a disease that is no longer responding to disease-modifying or life-prolonging treatments. However, research has shown that patients with cancer benefit from earlier integrated palliative care, particularly with challenging diseases like pancreas cancer. Thus, now we can say that palliative care is for any age patient and any stage of disease, including patients with pancreas cancer with curative intent treatment plans. Palliative care is there to support the patient and family through a life-threatening illness, in this case, their pancreas cancer journey. And when the treatment plans are curative, to support them through the process of their pain and symptoms and other decision makings. With treatment plans that aren't curative, the treatment goals may change over time, and the role of palliative care can also change over time. The palliative care team may step in more or less to help with symptoms and improve quality of life depending on the current needs of the patient and family. That brings us to the next question. What is the difference between palliative care and hospice care? When the disease does continue to progress or the treatments stop working, patients with pancreas cancer may begin to face discussions and decisions about end-of-life care. One question that frequently arises in my experience is, what is hospice and what is the difference between palliative care and hospice? It's important to understand that end-of-life care is one component of palliative care, and that includes hospice. But not all palliative care treatment is focused on end of life. Palliative care may be provided at the same time as chemotherapy, disease-directed treatments, surgical interventions, and life-prolonging therapy. Hospice, on the other hand, is focused purely on symptom management and comfort care at the end of life. Palliative care and hospice both share a common goal of alleviating distress and enhancing quality of life, but take place at different times in the disease course. Here you see a different graphic, again, of the cancer care continuum, but this is the graphic of the cancer care continuum from the perspective of hospice. So what then is hospice and who should consider it? Hospice is care for patients and families at end of life. In this graphic, we again see the palliative care integrated and growing in its role and its importance, while disease-directed therapies such as chemotherapy are being given. But in the purple, you see the transition to hospice. And in this hospice care graphic, you also see a new stage of cancer when cancer is not cured and is terminal, which is the bereavement stage and includes the family. Hospice care focuses on the patient who is no longer benefiting from cancer-directed therapies, such as chemo or surgery, and focuses on supporting the patient's comfort at the end of their life. This can be hours to days, days to weeks, or weeks to months. Hospice is thus a philosophy of care focused on patient comfort, dignity, and quality of life, and helps patients to navigate the end of their lives. Hospice services can take place at home, in the hospital, or in a facility. And this brings me to my second point, that hospice is truly two things. It is a philosophy of care, as you see detailed on the slide, but it is also an insurance benefit that provides specific levels of care and specific services to eligible patients. Eligible patients are those with a life expectancy predicted to be less than 6 months if the disease is allowed to run its natural course. In that sense, it is important to know that hospice is a covered financial benefit that normally is given in the home and includes connections to nurses on call to call with questions, some small amount of assistance in the home, and support such as medications, a hospital bed in the house, or other home safety adaptations. However, it is rarely 24-hour care, except under short-term limited conditions, and the burden of the 24-hour care still remains on the family or private pay. Patients with pancreas cancer will potentially benefit from hospice at different times in the course of their disease, depending on their treatment options, depending on their personal needs, depending on their goals of care. Each person is different, and one goal of palliative care, of the palliative care team and palliative care in general, is to help patients and families navigate these types of decisions, such as when to enroll in hospice when the time arises. And this is also an important role of the oncologist over the course of the illness to help the patient with decision-making about disease-directed therapies versus comfort measures. And this brings me to my final point of this talk. The goal of providing palliative care to people with pancreas cancer is to provide patient-centered care. The goal of palliative care and oncology treatment teams is to provide the patient with the care that is right for them, that is individualized, and that aligns with their goals and values. Part of that can be helping patients and families understand their disease, understand their treatment options, and understand their expected outcomes. It can be supporting their symptoms and treating their pain, and it can be providing emotional support to the patient and family. Of course, this can and will change over time for each individual person, and it's important to have an open and ongoing communication and discussion between patients and their medical teams as to what the current course of treatment and future looks like. And that concludes my section. Thank you very much.
Thank you, Dr. Baum, for educating us on the personalized and holistic approach to care that we pursue here at Smilow. We'll get started with the question and answer session now. And maybe I'll start with one of the questions for Dr. Farrell. How does someone get involved in genetic testing for pancreatic cancer? Does your oncologist make a referral? Is testing done during chemotherapy or afterwards?
Okay, thanks for that question. So I think it's important to start by saying, for the purpose of terminology, there are two types of genetic testings. There's testing on your blood and there's testing on your tumor. Both are typically initiated by the oncologist. The oncologist, for certainly when they're trying to come up with management plan, will request that the tissue, the tumor, be tested for mutations, which again, Dr. Lacy alluded to. The issue of germline testing, whereby your blood is tested to look for those inherited genes, is also typically initiated in that setting after a diagnosis by the medical oncologist, and the patient is referred to the cancer genetic services here at Smilow. They then undergo formal cancer genetics counseling, blood tests are ordered, and then when the results come back, they're shared both with the oncologist as well as the rest of the team. So those are two different strategies whereby a patient would end up with genetic testing. For family members who are concerned about their risks, they can also seek out the cancer genetic services to inquire about their risks. And also now that we have specific disease-specific clinics such as pancreas and breast, as well as colon cancer for individual cancers.
Great. Yeah, we had a question in the chat and one in the Q&A about chemotherapy. Maybe I'll refer this to Dr. Lacy. There's a question about how many cycles of chemotherapy are given, what are the side effects, and are there any new pills that could target the tumor site only to avoid some of those side effects?
Thank you for that great question. You've hit some of the really key aspects of chemotherapy treatment for our patients. So I mentioned fulfillingox a lot in my talk because I think it has probably had the greatest impact on improving outcomes in terms of survival. I also mentioned it is at some expense with respect to side effects. So with regards to fulfillingox, for patients who are operable and surgery is a part of their overall management plan, the recommended duration of chemotherapy is 6 months, which translates into 12 cycles. We do treatment every other week, so about 2 treatments a month. There is some emerging data that the duration matters, that patients who get all 12 cycles, even if there's some delays in dose reductions, do have a higher cure rate. And so we really aim to achieve that goal. In some cases, we will be giving the chemotherapy before surgery, depending on whether there's a need to do that. Usually that's driven by vascular involvement, or in some cases, some chemotherapy before and some chemotherapy afterwards. Fulfillingox is or can be, it's not in all patients, a tough regimen. And it is a little bit involved because patients have to be in the office for at least a good half a day to do the treatment. It's 3 chemo drugs plus a vitamin that have to be infused, and it takes a while, along with the pre-medications for nausea. And then when they leave the office, they will continue to have one of the drugs infusing with the home portable infusion pump for 2 days. So it's a little bit cumbersome. And I do know that patients get tired of coming into the clinic every other week to get fulfillingox. In terms of side effects, it is highly variable, and I have yet to identify those patients who will sail through it and those patients who will struggle. In general, we say that older, frailer patients will have a more difficult time and more toxicity, and I think that is true. But other than that, it's actually quite difficult to really identify in advance what we're going to encounter in each individual patient. Common side effects are feeling tired, altered taste, some nausea, queasiness, which we can manage usually quite well. An odd side effect of this regimen is something we refer to as cold sensitivity. Every time the patient touches something or drinks something cold, they get a very unpleasant, obnoxious sensation. And none of those side effects are serious, but they affect quality of life. There are a few serious side effects. One is risk of infection. That risk is quite low with the supportive care that we have, but still infection in the setting of chemotherapy can be serious or even life-threatening. And the other serious side effect is severe diarrhea, which can happen in about 5% of patients. Some patients don't have serious side effects, but they just kind of feel crummy all the way through. So, it is a bit of a Pyrrhic victory with fulfillingox, and, we wish we had an easier regimen, both in terms of administration and side effects. Gemcitabine and Abraxane. So let me pivot back to the other part of the question is duration. So for resectable disease, it's 6 months. For patients who have incurable advanced disease, in pancreas cancer, we generally prefer not to just stop all the drugs and take a chemotherapy holiday because the likelihood of the disease becoming active again quickly is high. But it is difficult to be on a regimen like fulfillingox indefinitely. So we will tend to modify the regimen as we go along and withdraw drugs to make it more palatable for patients. The other regimen, gemcitabine and Abraxane, is easier in the sense that there is typically not the nausea and the diarrhea. So the GI side effects, the gastrointestinal side effects are much less prominent. There still is the fatigue and the risk of infection. There is more hair loss with gemcitabine and Abraxane, I think, which is definitely an issue for a lot of patients. So again, these have made a difference, but they are not the easiest regimens. There's no question about that.
And then the second part of the question is, are there ways of making these drugs target more specifically the tumor and not the other sites? Maybe I will jump in here and say that this is clearly an active area of research. We would love to minimize side effects and maximize effects on the tumor. And there are several approaches that are being currently tried in preclinical studies, so prior to getting to the clinic, as well as in clinical studies, to mix drugs into particular nanoparticles, so small particles that you can put various things on the surface to try and direct it more specifically to the tumor cells. Another approach is to conjugate these drugs to specific proteins called antibodies that can detect particular other proteins that are specific to the tumor cells and perhaps would lead to less side effects to normal tissue. So it's clearly an active area of investigation to try and improve tumor-specific targeting and to minimize side effects. Maybe we'll move to the next question. For Dr. Farrell, what percentage of pancreatic cancer patients have no identifiable risk factors?
So I focused in the talk more on the familial or genetic aspects of it. And the reality is that the majority of patients presenting with pancreatic cancer do not have those risk factors. They don't have an identifiable strong family history, or when you go looking for a germline mutation, one of those mutations. And so we consider this group to be sporadic. But there are, of course, a whole bunch of lifestyle issues that may increase your risk for it. So smoking, we alluded to, obesity is certainly a factor in there. Race has also been considered a risk factor, with African Americans having an increased risk of developing pancreatic cancer. The idea, of course, that there are people who don't have obvious risk factors developing pancreatic cancers. Unfortunately, we see this, and it can be quite alarming to try and understand exactly what were the factors in play here, probably related to issues of microbiome or some other environmental exposure issues. So again, it's about 10, maybe to 15% that either have a familial and or a genetic risk factor that we can test for. For the remainder of individuals, a fair percentage have identified risk factors, but yes, there is a percentage of individuals who, when you go asking, do not have a clearly identified risk factor for pancreatic cancer.
And then we have another chemotherapy question, I think best referred to Dr. Lacy. What percentage of your patients develop resistance to fulfillingox, and after how many infusions?
Right, so here we're talking about patients with advanced disease, either locally advanced, unresectable, who are not going on to surgery, or metastatic disease. And you know, both of these groups will eventually stop getting benefit from fulfillingox. We will see that the tumor is progressing and the tumor markers are going up, and we will conclude that the chemotherapy is no longer working. So those patients have developed resistance. There are many complex mechanisms that are involved, some of which we understand, many of which we don't. But it is inevitable, really, in the vast majority of patients, that at some point, the chemotherapy will stop working. So the average time, you know, I don't like these types of numbers because no patient is an average and it is all over the map. But in the initial clinical trial with fulfillingox that was presented in 2011, it was about 5 to 6 months before patients developed resistance with the chemotherapy stopped working. But I would say that there's very significant percentage of patients who derive benefit from this regimen much longer than that. And I have had patients on fulfillingox and then transitioning to a maintenance regimen for a couple of years. So it is hard to draw conclusions from some of those averages for an individual patient.
And we're running short on time, so maybe I'll ask the last question to all of you, and maybe start with Dr. Salem. What are you hopeful for pancreatic cancer care now and in the future?
So that's really a good question. You know, pancreas cancer has just been difficult in so many different ways. You know, the diagnosis is difficult, the radiology is difficult, the surgery is difficult, the chemotherapy is difficult. Nothing is easy about pancreas cancer. But really, I think what you've heard today is the improvements in chemotherapy. You've heard about the improvements in early diagnosis. You've heard about the identification of genetic markers that can help us. And really also, of course, the most important, you know, palliative care, because so many of our patients do require that eventually. So what I would hope for really is improvement in all of these areas. And I think all of these areas show promise. And I think that's what makes it exciting for us. And, you know, the challenge is not insurmountable. And I do believe that in all of these areas, we will see progress over the next decade.
Dr. Baum?
So it's a good question. Since I gave the palliative care talk, maybe I'll say a non-palliative care answer, which is that I always think about, and I'm not very old, as you mentioned, I'm the most junior person here. So when I was in residency at NYU, there was a physician, a medical oncologist, who did all of the treatment for the metastatic melanoma patients. And I thought, oh my God, who would want to do that? It's such a difficult disease. They do so poorly. And then there's been really, truly disruptive innovation, really huge developments where we see metastatic melanoma patients being cured with novel therapies. And I think that for pancreas cancer, what has to happen in our lifetime and soon is some kind of big new way of thinking and scientific change that we don't see coming, and that makes this a more easily treatable cancer. I think that is the real way to think about that. There's things that we don't know about yet, and that there's scientists working on it. And then I do hope that with patients who are currently dealing with pancreas cancer, that we will be able to give them the treatment that is best for them, and that that gives them the best outcomes possible under the current circumstances.
Dr. Farrell?
You know, when I go back and look at things that I wrote about pancreatic disease 10 10 or 15 years ago, and I realized how much in the dark ages we were, and how much progress has been made, at least in our understanding of diseases. We're a lot more sophisticated about how we think about it. There's been a lot of exciting research in this area. And so it's slow, and sometimes the applications to patient care to improve patient outcomes and quality of life are slow, but they are actually happening. And I think that's where I kind of take a lot of solace from. This is a long game. This is not a sprint. This is a marathon for all of us, especially our patients. And so, you know, I'm optimistic that we're going in the right direction. Yes, it's going to take, there's some other major achievements that have to be made. But when I look back and see where we've come from and, you know, what we have gained over the last 5, 10 years ago, I mean, not just in the diagnostics, but even in the therapeutic area, you know, I'm optimistic for the future and for our patients.
And Dr. Lacy will give you the final word.
Oh, well, thank you everyone for your comments, because you have basically expressed my thoughts. So what's left? So what's on my wish list for this disease is a prevention strategy. We know that there's a very long latency period where those pancreatic ductal cells are undergoing changes. They are preneoplastic, sort of analogous to the polyp in the colon that takes 10 years to turn into a cancer. Now for colon cancer, we can remove the polyp. It's not so simple in the pancreas, but if we could identify a medication that has few side effects and is effective in reversing some of those changes, I mean, that would be for me the most incredible breakthrough for this disease. Short of that, getting back to we are where we are in early diagnosis, patients present with advanced stage disease. You know, we need the kind of breakthrough they had in the melanoma field, as Laura alluded to. Is that going to come from immunotherapy? I think many of us think so, because that's where the major breakthroughs have come with other diseases. But we may be surprised. Maybe some of these other strategies or combinations of strategies will give us that giant leap forward that we're all hoping for.
Great. So it's clear that clinical care is slowly improving in pancreatic cancer. And I think, as everyone alluded to, research is hopefully going to make major breakthroughs in the coming years. And so on that hopeful note, I want to thank our speakers for their insightful comments and educating us today, and also thank all of you at home for your attention. Have a great evening.